it's our honor to invite Dr. Ibrahim Maigari. He is a consultant physician and lecturer in infectious diseases at Abu Bakr Tafawa Balewa University Teaching Hospital in Nigeria. He is the head of infectious disease unit and coordinator of infectious diseases treatment center, and he heads the largest isolation center for viral hemorrhagic fevers in the country. He is also fellow of the West Africa College of Physicians and has MPH and diploma in infection prevention and control.
Yes, can you see it as full screen?
Yes.
Okay, thank you. Good day, everyone. I'm happy to be here to share my experience and what I know about Bundibugyo Ebola Virus Disease. As introduced by Dr. Dhanya, I'm Dr. Ibrahim Maigari from Abu Bakr Tafawa Balewa University Teaching Hospital in northeastern Nigeria, an area where we have viral hemorrhagic fevers. More commonly is Lassa than Ebola, but we treat various types of viral hemorrhagic fever, including yellow fever. So I will take my presentation through this following outline. I will give a brief overview of the teaching hospital and the viral hemorrhagic fever treatment center. I will introduce Ebola virus, including classification, and then the Bundibugyo species. I will also talk about the reservoir and transmission, the clinical features, diagnosis and management, and discuss a bit about the past and current outbreak. And then also have some few words on what hospitals should do in order to prepare, as Ebola virus may actually go to any part of the world because of the ease of transportation. So this is the second gate of my hospital, the Ebola Tafawa Balewa University Teaching Hospital. It's a tertiary referral hospital in northeastern part of the country. And this is the Infectious Disease Treatment Center. It was first opened in 2014, and since then it has been managing viral hemorrhagic fevers, including Lassa fever, yellow fever, and some cases of dengue fever as well. This is also part, because of the increased number of cases, we have to expand beyond the permanent building into all these structures. And this area is for the confirmed cases. And we have a lot of staff that actually cater for this patient. By the end of 2025, we actually managed 250 cases of Lassa fever. And then, as we are all aware, Nigeria had the Ebola viral disease in 2014. Then we had about 19 confirmed cases and then 6 deaths, though most of the cases were actually at the entry points of the country, mainly Lagos and Port Harcourt. So this is the inside of our isolation center. You can see it's made in such a way that the physical barrier is there, but there is this transparent look into barrier that gives closer monitoring of the patient in as much as they are highly contagious, but they are closer to the healthcare workers. So any deterioration can be quickly detected and then can be acted upon. On the other side, on the right-hand side, is an ambulance arriving at the triage center, and you can see some staff trying to decontaminate the ambulance before leaving. So this is inside the triage area where we actually screen to confirm that the patient coming into the treatment center is actually a case of viral hemorrhagic fever or not. And then to do that, the personnel doing it must be properly kitted, as we can see on the photograph. On the right-hand side, the health education area, because the family members, the caregivers are very essential in managing viral hemorrhagic fever. So we educate them, we pass the message of preventive mechanisms, and then they need to report early when they have any symptom of viral hemorrhagic fever, because they are already close physical contacts of these patients that are coming. So Ebola viral disease, the Ebola virus itself is a prototype of viral hemorrhagic fever. It's associated with so many outbreaks since 1970s, with the case fatality that can be as high as 90%, especially with the Zaire subspecies of the Ebola virus. And usually the outbreaks are confined to Central and West Africa. However, the problem with this viral hemorrhagic fever is the clinical presentation resemble or are almost exactly similar to many tropical febrile illnesses that we see in Africa and other parts of the tropic, most notably malaria and typhoid fever. So that make it very difficult to distinguish from other common febrile illness. And then if these things are missed, then the patient wakes dying from this uh, uh, other more common febrile illness instead of the viral hemorrhagic fever or Ebola that we may be thinking they have. So there are about 5 species of the Ebola virus. The Ebola viridae belongs to the phyllo viruses, where we also have something like Marburg. However, the species include the Zaire, Sudan, Preston, Typhoid, and Bundibugyo. And 4 of these species have been known to cause diseases among humans. The latest to be discovered is within the Ebola virus and the cause of a current outbreak of Ebola viral disease in Congo and Uganda in Central Africa. So this image is showing the spread of the outbreak over the past 16. However, if you can see, the yellow part is showing where the Bundibugyo viral outbreak occurred since 2007, confined mainly to the Democratic Republic of Congo and the bordering country of Uganda. Even this current outbreak is actually confined between these two countries. So the Bundibugyo viral disease is actually a very deadly viral febrile illness that is associated with acute fatal hemorrhagic disease with humans. It causes outbreak in the past, and then it's responsible for considerable number of deaths. In the past, it's associated with about 25% mortality, though it's a bit lower than what is observed in other species of Ebola virus like the Zaire species. It was first detected. So I was talking about the viral transmission, and the last bulletin I was talking about was the secondary transmission, which is usually through infected fluid and blood of patients that are affected, and this include those that have died of the illness. And the usual practice in Africa of handling the body of someone that died usually involves direct physical contact and is usually unprotected. So that's serve as a mean of exposure and even a mean of propagating the outbreak. This has been demonstrated in the past outbreak of Ebola viral disease. So humans can also get infected through indirect contact with those with someone that is infected or the body of those that have died of the disease through the infected clothes and also the infected produce that is special because handling such a thing in form of maybe trying to clean it can actually lead to contamination of the skin, which will have been broken, and then the viral entry into the body. So these are some of the ways that this Ebola virus can infect humans. The clinical features usually develop following an incubation period of about 2 to 21 days, though the average usually is seen within 3 to 8 days, and it's usually shorter during from following primary exposure, but longer during the secondary exposure. Even though this is not a hard and fast rule, it can actually be shorter or longer either of ways of exposure. Usually, the symptoms begin with sudden onset of non-specific illnesses that can be explained by most of the tropical fever illnesses. Usually, severe fever, high fever, severe headache. There is this disturbing myalgia and arthralgia. People may have anorexia and sore throat. This usually is noticed between the first 4 days, and this can progress to more gastrointestinal symptoms where the patient become weak. And at this time, usually the infectiousness is usually very high, and the patient usually vomits, have diarrhea, may have severe abdominal pain. Other symptoms have been observed. This is according to the WHO Ebola response team in 2014. Uh, include headache, confusion, eye, coma, mental obtundation, and other neurological features. Chest pain, they may have even respiratory distress, they can have cough, dyspnea, hiccups, the gastrointestinal symptoms, and also hematological symptoms, which is mediated by bleeding. And this bleeding can be in form of epistaxis, can be in form of vaginal bleeding, or even miscarriage, or prolonged normal menstrual bleeding can be gum bleeding, uh, uh, can be hemoptysis, or can even be bleeding at the injection site. Maybe in the trial of cannulation, the bleeding will not stop. And also, some of these patients also present with eye issues, including conjunctivitis and then conjunctival injection, which usually make people to suspect that this may be a viral hemorrhagic fever. After around 5 days, some people usually also notice maculopapular rash, and this is responsible for this condition that is in among survivors of Ebola viral disease. The virus often progress to uh, more severe form and complication with multiple organ dysfunction, and then uh, the bleeding may become more profound, and this bleeding can be both internal and external. And then you see begin to see features of multiple organ failure as a component of sepsis. Commonly affected are the kidneys, and the kidneys are affected because of the high level of fluid loss if fluid therapy is not properly done, and then the virus infecting the kidney as well. uh, this can predispose to kidney failure. The liver is also one of the organs that is commonly affected. The virus directly infects the hepatocyte. It leads to hepatic necrosis with formation of cancer bodies, just like what you usually notice among patients that are infected with yellow fever virus. And this is responsible for the jaundice that the patient are usually seen with, and that is also responsible for the high elevation of the liver enzymes observed. At the triad, it's always better to rule out common febrile illnesses, so do something like malarial test, and then also ask history and they suggest the person may be having typhoid fever, because these are more common than Ebola Bundibugyo viral infection, especially unless there is an ongoing outbreak. But even during an ongoing outbreak, usually the prevalence of malaria or other tropical illness is even more among those that are suspected to have Ebola viral disease. So some of those investigations that will make increase the suspicion of Ebola viral disease include something like urinalysis, where you see proteinuria and hematuria, and that can be done even at the triage area. And they give more investigations are done. You see thrombocytopenia, leukopenia, and leukopenia. The virus actually, especially at the initial state, is known to depress the blood cell rise. So leukopenia, especially, is very marked, and this is due to the some of the virulence factors of the virus that actually infects leukocytes, like the secretory glycoprotein. It stops the activation of neutrophils and even interfere with general cell-mediated and even humoral immunity. If liver enzymes are done, you see elevated transaminases as are usually more elevated than ALT. This is a picture of showing patients that have suffered from Ebola. You can see the bleeding. Like I said initially, the bleeding can be both internal and external. And usually, what we observe from our experience is clinicians wait for this bleeding to suspect viral hemorrhagic fever. But by the time these patients are bleeding, usually they are in stiller stage, and mortality among these patients is very high. So early identification is very key. And at this stage, usually they must have been to several hospitals, after with several healthcare workers. So you see a lot of contacts, which may likely develop the illness. And the other right hand side, you can see the conjunctival hemorrhage that this patient can also present with. The bleeding from site of cannulation, usually even before it going, whenever there is one or two attempts, you see it bleeding. That takes a lot of time to actually stop, or may not even stop. You have to prepare your pack, and then you can even see bleeding in the gingiva. So the management for Bundibugyo Ebola viral disease for now is mainly supportive. There is no approved specific therapy, and there is not approved vaccine for it. So the mainstay of treatment is actually supportive because of the wetness, the predominance of gastrointestinal symptoms, the bleeding. So fluid therapy to maintain fluid balance is very key to actually improve survival. So efforts should be made to monitor electrolyte imbalances and then correct as they are detected and unfold. Bleeding. The bleeding can actually be severe. What we see as external bleeding may actually be a fraction of the entire bleeding the patient may be having because there may be an ongoing internal bleeding. So blood need to be replaced, components or whole blood that may have some clotting factors uh, to help in stopping the bleeding should be given. Even though we know Ebola viral disease, the virus actually invade the endothelial cells, causing endothelial destruction, and this is what is usually causing the bleeding. So it's a bit difficult to actually control, and this bleeding is seen is about 50% of this patient. Then the multi-organ failure that is happening, support should be made to support the kidney, to support the liver. Some of these patients even require hemodialysis because usually, especially toward the end of the illness, the cardinal stages is even have complete anemia and then a lot of imbalances in terms of electrolyte. And if this is not corrected, usually with too high mortality, pain relief, and then nutritional support to support recovery are very, very essential. So for diagnosis of viral hemorrhagic fever, usually PCR is done. It's very sensitive, and then it's the one that can be used to detect the infection even at an earlier stage. So and it's usually available in the public health laboratory, though the sampling actually should be done under strict IPC measures and should be triple packaged. The primary container should be inside a secondary container, and then another tertiary container should be done so that there will be no exposure even during transfer from the treatment center to the laboratory. So usually the setback with the PCR is it can also be negative even among uh, confirmed cases in the early stages as the viremia is building up. So usually if the suspicion is very high, the patient should be kept in the treatment center and the test can be repeated in 24 to 48 hours and in return to the positive. So ELISA can also be done to detect both antigen and antibodies, either the IgG and the IgM can actually be detected. The good thing about Ebola virus is the protective antibodies actually last for a long period of time. Unlike in other viral hemorrhagic fevers like Lassa fever, these are actually neutralizing and protective. So it confers some advantage to the survivors. Um, uh, there are so many things that may actually mimic the Bundibugyo viral disease and commonly infection with other Ebola viruses. Usually, the clinical presentation is that you cannot actually distinguish them clinically unless there is an epidemiological linkage, which can bring in all new suspicion. So it can be any of the species of the Ebola virus. It can be other filoviral infection like the Marburg, though Marburg is usually not as severe as Ebola viruses, but then it can be a very good differential. The other viral hemorrhagic fevers may be a good differential of this Ebola Bundibugyo species. Commonly Lassa fever, which is very common in West Africa and area, is also affected by Ebola viral disease. Though the source of transmission is usually different, but they are all zoonotic. Lassa fever is usually from the masculine right. But the presentation can actually be very, very similar, both in the early and the late stages of the infection. The only main difference is usually Lassa fever patient are usually less weight than Ebola viral disease, and that decreases the spread among Lassa fever patients compared to Ebola viral disease. Dengue is also a good differential. It's common also in the tropics, and then though it's spread uh, by mosquitoes, but then as the patient is presenting, the features can also be similar to Ebola virus disease. Premium or hemorrhagic fever. This can be spread by ticks, usually in settings of animals, and it's also common where we see other viral hemorrhagic fevers, including Ebola virus disease, including Lassa fever. So it's a very good differential. And then on the clinical ground, we may not actually distinguish it from the infection caused by Bundibugyo viral disease. Often forgotten are the bacterial hemorrhagic fevers. This bacterial hemorrhagic fever can actually give us the complete clinical features that we see in Ebola viral disease. Typhoid fever, unless you ask about history of soldiers and other things, and usually the definitive diagnosis may actually take time, so people tend to miss it. Meningococcemia can give us the bleeding, can give us the initial symptoms that can actually mimic Ebola viral disease. And we also have leptospirosis, usually commonly seen among steroid workers or those exposed to those rats. But then clinically, it can, especially the phase 2, can actually present very severe infection for bleeding disorders with jaundice that clinically can actually resemble viral hemorrhagic fever. So also rickettsiosis, this can also clinically resemble it, and especially those that live in the outskirts of the cities, maybe in rural areas. And this is actually where we see most of the viral hemorrhagic fever. Ebola virus inclusive, Lassa fever inclusive, Crimean Congo hemorrhagic fever inclusive. So this is also a very uh, important illness that we should consider among the patient we are suspecting Ebola virus disease of the Bundibugyo species. Malaria, which is very common in Africa and in severe form, can actually give us a state of similar to Ebola viral disease. And then usually the rate of co-infection can be high and it has influence in morbidity and mortality. So proper identification of malaria and institution of the right treatment will improve survival. So for the prevention, it's usually standard infection prevention and control measures. Once this is done, even if a patient that came into a hospital is not identified, at the end of the interaction, you see that the healthcare workers are at no risk because they follow the standard infection prevention and control measures, and this is advised across all hospitals. However, during outbreak, usually we should inquire more, we should be proactive in screening this patient, asking history of travel, somebody that is today seeing in many hospitals in India, in Nigeria, or any other part of the world may have been coming from DRC or from Uganda, and then he must have escaped maybe the epidemics there, and then he may be having Ebola viral disease. So among fever patients, we should ask his history or travel, which is very, very important in screening our patients. For the video viral disease outbreak, like I said, initially started in 2007, death in Uganda and causes 149 confirmed cases that are officially known and 37 deaths with a mortality rate of over 25%. In 2012, there was another outbreak in the Oriental province in DRC with 57 confirmed cases and 29 deaths, and the mortality rate then was 51%. And the ongoing outbreak, so far as of 2nd of June, there were 363 confirmed cases in DRC with 63 deaths, giving us the case fatality rate of 17.9%. And in Uganda, already there have been 15 confirmed cases that wanted. And what these are actually linked to Uganda. So it's likely a spillover from Uganda. So in Democratic Republic of Congo, the government actually reported a lot of challenges, which it is addressed actually to the containment of the outbreak. And this revolves around early detection by healthcare workers and isolation of this person because they need to be isolated so that other people may be infected. Contact tracing those living at home in the communities that have been exposed to this infected patient. Their handling of the dead bodies in a safe and dignified way is very, very essential because it can also lead to complication of the outbreak. Institutionalization of infection prevention and control measures in health facilities is a challenge because this requires culture, change in attitude, change in behavior, and commitment from the administration and the staff themselves. But then with continuous enlightenment, this is a possibility. There's strong community awareness. We know that there is no vaccine and there's not the strict treatment. So for healthcare workers, they have to continue the supportive care, which will give the patient better chance of survival. So for hospitals, you don't wait until there is a confirmed case, then you start thinking of where to manage, how to manage. So it's advised that An isolation clinic should already be identified. Staff to manage any case that may come should also be identified, and this staff should be well trained, especially in IPC and supportive care. There should be good wash items, wash materials, water sanitation, and hygiene. And then all the staff of the hospital, especially those working at the entry points of this hospital, should know about the Ebola virus disease, should know the clinical features, and should know how to screen so that when they see, especially febrile patients, they can quickly screen and look for this infection, and there may be to early identification and prevention and moving spread in the hospital. So this is what I have. Thank you for your time and thank you for listening. Oh,
Thank you so much for the excellent presentation.